Hello everybody. Today I will explain my ideas over the neuromuscular performance enhancer. Although this is not a cure, it may increase the quality of life and independence of a paralyzed patient. We will discuss the following topics. In persons with ALS, motor nerve cells gradually die, leading to progressive paralysis. Each year there are 3 to 8 ALS patients and in 1.5 to 2 new cases per 100,000 worldwide. There are approximately 250,000 existing ALS patients annually, among which roughly 50,000 newly diagnosed each year. In addition, these numbers are increasing, with approximately 90%. Sporadic ALS surpasses largely the familial version, which is heritable. An ALS patient experiences increasing paralysis. In the second step, a disturbed communication between motor neurons and supporting cells results in faster dying of motor neurons. Motor neurons and supporting cells communicate with each other and they influence each other gene expression. When too much motor neurons disappear, their communication gets disturbed. The expression of some genes of motor neurons stops while others are activated. Motor neurons do no longer operate properly in the microglia. The immune system of the nervous system no longer recognize them and destroy them. The attack on motor neurons still continues, but its effect is now negligible compared to the destructive activity of the disturbed communication. Patients with visible ALS symptoms cannot be cured and will not recover. The motor nerve cells and mainly their connections that are lost will not return or be replaced. Only treatment can bring some comfort. For them, we have to take a different road and focus more on a better quality of life instead of a cure. Possible ideas for this are: suppressing the destructive activity of microglia, improving the communication between motor neurons and supporting cells, improving the recognition of the own motor neurons, and improving the quality of life by driving devices, such as exoskeletons, speech computers and breathing devices with the brain. Also, the own muscles should be considered. A possible name for this could be the neuromuscular performance enhancer. We talk more about the latter. A system that drives devices and muscles with the brain should have 3 cooperating parts. At first, the driving signals of the brain should be read and understood. Further, devices and muscles should be operable by a comprehensible set of commands. Finally, the driving signals of the brain should be sent to the devices and muscles, where they will be translated into the correct commands to control the devices and muscles. Reading brain signals is mostly done by a network of sensors accurately positioned on the outside of the skull. For movement, one can limit the location to the motor cortex. Every sensor produces a series of event-related potentials, abbreviated as ERPS, in time. Devices, such as exoskeletons, speech computers and breathing devices, have subparts which drive them. One should be able to execute these individual control actions with a set of commands. Although more difficult, muscles should be regarded in the same way. The recorded ERPS of the brain sensors have to be sent to the devices and muscles. Currently, this can be done wireless and at a much higher speed than in the nervous system. Once arrived, the send-ups have to be converted into commands driving the devices and muscles correctly. There are also some practical requirements for such a system. First, it cannot need too much room and should stay operational during transport. There should be safety measures against a system failure, and it may not damage the human body. Although one has to install what is needed at a given time, new necessary modules can be easily integrated. Due to individual differences and a deteriorating physical condition, it should be easy to fine-tune the system in function of the needs. one has to take into account that controlling the system is a learning process for the ALS patient, and finally, it should be affordable for both the ALS patient and the insurance. The most meaningful action of the lower limbs for an ALS patient are to come upright. Standing and walking. Running might be too ambitious and is probably not necessary. Various exoskeletons for this are currently tested. These movements use normally mainly the leg and foot muscles. Exoskeletons also exist for the muscles of the shoulders, arms, fingers, abdomen and neck. These guarantee lifting, porting, grasping, maintaining a posture, bending and stretching the trunk and raising the head. Some exoskeletons try to cover multiple movements. There are at this moment even experiments to let them control with the brain. Beside exoskeletons, other helping devices are also used. A weakened or lost voice is sometimes replaced with a speech computer to battle the locked-in syndrome. Also, there is equipment to support the diaphragm during breathing. Eating, involving chewing and swallowing, is difficult to support with artificial means. For sure, one can offer food in such a way that chewing requires less force. Also, food can be kept moist and ground small to ease the swallowing and avoid choking. Some muscle support would be welcome here. One can eventually try to drive, instead of devices, the own muscles with the brain. Muscles can after all be regarded as the evolutionary solution for movement, which are activated by neural impulses. Mainly more than 600 skeletal muscles take care for human movement. They exist of muscle bundles which contain individual muscle cells. Each muscle cell has a cytosclid of which the contractile, fiber-like chains of the proteins myosin and actin are part. Each muscle cell has a neuromuscular junction where contact with the nervous system takes place. As an example, the bicep of the arm has approximately 250,000 muscle cells which receive their driving signals, electric in nature, from motor neurons. The muscle cells which are innervated by one motor neuron is called a motor unit. The abductor pollicis brevis of the thumb has roughly 230 motor units. But most skeletal muscles are guided by a maximum of 10 motor units. Most likely, small exterior electric currents can contract and relax muscles in a controlled way. For a certain movement, several muscles have to contract or relax. In addition, time also plays an important role in the realization of a coordinated movement. Luckily, we do not have to obtain perfection. Each improvement compared to the current condition is a bonus. Something like this should be tested and fine-tuned in a pilot project. Of course, not all movements can be investigated to evaluate the principle. Manual grasping and twisting is, according to me, a good compromise between big movements and those that require fine motor skills. It could be the focus of a pilot project without bringing the experimental subjects in danger. Such a pilot project could be the beginning of the development of the neuromuscular performance enhancer. Persons with multiple sclerosis are also confronted with paralysis. A neuromuscular performance enhancer device should therefore also be useful for these patients and all people that have some kind of paralysis. In addition, it would considerably increase the number of potential users. When the muscles themselves are affected, like in Becker's muscular dystrophy, Duchenne muscular dystrophy and other muscular dystrophies, artificial steering of muscles is of course not possible. However, these patients could eventually help with a system that uses ailing devices. In such a research project, multiple disciplines have to cooperate. 2 civil engineers can be responsible for reading and sending the ERPs generated by the motor cortex. 2 biomechanics specialists of the Faculty Physical Education and Movement Sciences may investigate how individual muscles can be steered artificially and how hand muscles can cooperate in order to grasp and turn keys. A bioengineer may coordinate their activities and convert the recorded brain ERPS into the appropriate muscle activity in order to realize the complete system. Together with some additional helping staff and material, a budget of approximately €1 million is required for the realization of this project. The multidisciplinary group Science and Technology of the KUL, headed by Vice Rector Gerard Govers, might offer the right platform for this pilot project. There is still a lot of work to do after the realization of the pilot project. After a successful outcome, other movements could be dealt with. First, the easier, independent increasing movements for coming upright, standing, walking, lifting, maintaining a posture, flexing and stretching the torso and raising the head should be investigated. After these movements, more difficult ones like the fine motor skills of the hands, talking, chewing, swallowing and breathing can be handled. Furthermore, each movement module should easily be integrated in the existing system named the Neuromuscular Performance Enhancer. At the same time, one can work on its practical application. Medicine can test it further on patients while the industry may bring it on the market. The same bioengineer can be of assistance, because it is not a medicine but a helping device. Expensive, long-lasting clinical studies are probably not required.